Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I'm a filmmaker and writer that's been working with CCF for about 10 years, actually a little bit over 10 years. I think when I first met the team, it was, I want to say 2011. It's almost 2023, which is wild. But in that decade plus, we've created I don't know how many videos, lots of videos, hundreds of videos over the course of that time. We have done live video series, Q&A sessions like the one you're going to watch today, patient-centric documentaries, treatment-based videos, conference videos, short social media videos, but all with the same singular mission in mind, and that is to help spread awareness and education about neuroendocrine tumors. That is what we are here to do. Now, the value of this show, if you are new to it, first of all, I want to say welcome, but the value of this show is twofold as I see it. One, the information that you're going to get from our guest and the answers to your questions, hopefully. But two, the support, the shared stories, the shared experiences from the community that we've helped cultivate on the show. Now, I can't take credit, and we can't take credit for the overall NET community, which is extremely powerful, extremely supportive and strong. I think CCF plays a big role in that, but here on the show, you can see the micro version of that as well. So I encourage you to reach out. You see people in the comment section saying where they're from, saying hello. I encourage you to do the same thing. We've got people all over the country so far, and we'll start seeing people from all over the world. Introduce yourself if you're new to the community. Embrace the community. They will embrace you back. I promise you that is a very, very valuable aspect of this show. And one thing that I have heard repeatedly from our guest is that it's helpful for them too. The feedback, like this is not just a one-way lecture. This is a conversation. And so the input that you give, the experiences that you share, the questions that you ask are just as valuable to the experts that we have on. Now, before we get started with our very special edition of the show today, I want to thank our sponsors, Ipsen Biopharmaceuticals, because simply without their support, we couldn't do the show. And so we have this disclaimer from them, and that is that the opinions expressed by the guest presenters, as well as the questions asked by you all, the audience at home, haven't been created or suggested by the sponsors of Luncheon with the Experts. And CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guest, and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Okay. So we're going to give you some good general advice and answers to your questions, but we don't know your specific case. So take that advice and those answers back to your home team, which does, and make the best plan and path forward for you. Now, today, I've already alluded to, we have a very special episode. I'm excited to have a guest back on the show who we had before, but in a special format. Today, our guest is Dr. Mariam Aboian. How are you, Dr. Aboian? Welcome back.
Hi, how are you? Thank you so much for inviting me back.
Absolutely. I'm doing very well. And before I have you introduce yourself, I want to give everybody a little bit of context. We also have a special guest who is in the waiting room who will be arriving soon. Dr. Aboian is at the Nanets Symposium in DC, which is happening right now. See there. And she peeled away for an hour to do this for us, which I'm so grateful for. But hopefully we can get some insight into some of the things she's already learned this morning and what's going on. And of course, as always, answer some of your questions. Now, Dr. Aboian, for those who didn't see your first episode of Lunch with the Experts, tell us a little bit about what you do, where you work, and your focus in the neuroendocrine tumor community and world.
Oh, yes, thank you so much. So I am from Yale University. I'm a nuclear medicine physician and neuroradiologist. So that means I split my time between imaging of the brain and spine, and then I also do nuclear medicine imaging with novel PET tracers and also therapies. So right now I'm actually the director of the Diagnostics Center here at Yale, and we're building very kind of new paradigms in terms of how to treat patients with radio therapeutics. And we're really trying to focus on patients and really making sure that you're being heard and we incorporate clinic visits with nuclear medicine physicians. I also do a lot of teaching and I do a lot of research. So I lead a large lab in computational imaging of cancer, where we actually bring in design tools that are artificial intelligence based, and we bring them into clinical practice to provide quantitative assessment of disease and treatment response. So we're trying to put a lot of mathematics into clinics so that you actually have quantitative data on your, our patients have quantitative data on their disease.
Got it.
And then on top of that, I also run a preclinical lab where we study radiation-induced damage, and particularly on normal organs. Right now, we're focusing on the brain because a lot of times radiation or chemotherapy can have pretty significant effect on cognitive function. And we're trying to characterize the mechanisms of how chemotherapy and radiation can cause damage to the brain. So this is my multifaceted approach.
I see. So impressive. A lot going on. Folks, I told you that we had an international crowd that would be joining us. And here we have S from Belize, a first-time joiner. Welcome. I'm actually visiting your beautiful country in a couple of months. I'm excited about. Hello to Maurice from Ireland. Now, folks, what we're going to do today, because you can see Dr. Aboian is not in her office, but in the lobby there at the symposium. So we may hear some background noise. Look at that. That's so cool. This is totally behind the scenes. So what I've asked her to do is just in the meantime, if it gets a little loud, she may be muting herself when she's not speaking, just to give you a heads up on that. And I have one more announcement before we let in our special guest. This is actually our final show of the year. We are done for the rest of 2022, holidays coming up and all that. But the good news is we have found sponsorship to do this again in 2023. We've done this now for 2.5 years, this show. So stand by. I'll certainly let you all know as we get there, but the next episodes will be into 2023. So I'm really excited to end on this grand note, this grand episode. And with that said, I am going to welcome in our new guest. I'm going to go ahead and let her know that we're live. So just a heads up, welcome to the show, Dr. Pam Kunz, our friend. How are you, Dr. Kunz?
Hi, how are you guys?
We're doing well. We just went through announcements, told everybody, we showed them a little behind the scenes peek at what's going on there. Really, really appreciate you being here. How's your day going so far?
Good so far. It's lots of fun.
Yeah, good.
I'm hiding in the networking lounge. There's no one here right now, so I'm
fancy.
All good, yeah.
Fancy. Well, we got some questions coming in already, and we'll try to field them and just have a chat. But my first question, I want to learn a little bit, Dr. Kunz, while we have you, about, is there a particular theme this year? Like, what are we focused on? What's the highlights of this year's symposium? What are the standouts? Talk to me all about it.
Well, we're just getting started. And I know this is Dr. Aboian's first NANETS, so I think that would be good to hear her impressions also.
Absolutely.
And this is my 11th NANETS. So wow. It's, I came to my first NANETS. I brought my 6-week-old youngest son with my mom to the meeting. So it was impressive. A long time ago. But I'm excited. Our meeting continues to grow, and we actually have some parallel sessions this year, which we haven't historically done. It's hard to pick. I have to say, for what I've attended this morning so far have been sessions with some of the early career investigators, which has been really exciting. That's the future of NANETS for sure. And really inspiring. I think it shows a lot of great mentor-mentee relationships from some of our established kind of more mid and senior career investigators, really bringing along some of their trainees. And I love to see that. I know that Dr. Aboian's also really big on mentorship. And the other thing I'm excited about this afternoon is the new NCI, or National Cancer Institute, collaboration with NANETS. We are in their backyard in Washington, D.C., and we felt that this was really just a fantastic opportunity to take advantage of that expertise. This was really spearheaded by Dr. Heidira Del Rivero, who is part of the NCI. I know we all love Heidi. And so I'm excited for that this afternoon.
Yeah, she's the best. She's been on our show, I think, 3 times now and very recently. So we talked about this a little bit. What about you, Dr. Aboian? What's been your experience so far? I know we're early into the first day, but it's got to be exciting.
Oh, tremendously. I've been tremendously lucky to get to work with Dr. Kunz because she's one of my big mentors, and she's teaching me in terms of how to succeed in the field of research in neuroendocrine tumors. And it's been such a wonderful experience because, we started discussing different ideas over a year ago and how to form projects. And we're right now in the process of developing how to put these projects together, but it's not easy.
Right.
Research is extremely hard.
Right.
So even as a faculty, I'm a junior faculty, I still need mentors. So I need Dr. Kunz to show me how to.
I still need a mentor.
Don't we all?
Yeah.
So talk to me. Oh, sorry, please continue.
No, this is, yeah.
Your point about how to have success with research specifically in this disease. Talk to me a little bit about the unique challenges in that realm for neuroendocrine tumors specifically.
So a lot of times it's such a rare disease. So it is actually sometimes really hard to come up with really good data sets to study, and that are very well characterized. And a lot of times to put a good data set, you have to have multiple institutions. And this is where it's so fantastic to have mentors like Dr. Kunz, because she has been in the field and she has the collaborations with so many different institutions and then CI. And she was just telling me about this amazing study that she spearheaded at the ECOG-ECRIN. I'm gonna leave that to you.
Yeah, no, I can certainly add to that. I think really one of the strengths of NANETS is bringing together multidisciplinary researchers in a rare space. And, Mariam and I just this morning, we're talking with a surgeon, and, there you go. In that conversation itself, we had a medical oncologist, a surgeon, and a nuclear medicine specialist, and we were brainstorming a collaboration. Honestly, to be back in person is also so helpful for that networking. And we have lots of breaks and opportunities to have that networking. And I think that's really where organically some of these teams are built. One, I would say just a direction for medical research in general is really more of a focus on team science. No longer can we as single researchers get the science done. And I would say that's especially true in NETs and in rare diseases. And as we, for the audience, as we think about writing new research grants or new clinical trials, it's absolutely a must that we do that as a team. And in NETs in particular, we need various specialties represented on that team. And I think that to be able to do that is exciting, and it's often really the seeds of those ideas happen at meetings like this.
Yeah, honestly, you answered my next question. I was going to ask about that, how important it is to have these types of events on the larger, grander scale, like NANETS, and then with multidisciplinary teams. It seems to me very, very important for this disease specifically to have that collaborative approach. And you kind of confirmed that. I want to go ahead.
Rain, can I add one thing to that?
Always.
So one really exciting new effort at NANETS is that we are really trying to bring in more specialties. It tends to be a pretty medical oncology heavy membership. But I think because of this focus now on nuclear medicine therapies and on the need for team science within our membership, we are developing groups called special interest groups that are for professionals in the NET space, whether they be sort of physicians or researchers, but really to bring, so as one example, we have recognized a need to have more gastroenterologists as part of our membership. So we have a special interest group that's being led by Dr. Bryson Katona, who is a gastroenterologist at Penn, and to bring together gastroenterologists throughout the US who may have an interest in NETs. And I think we could apply that same thing for any number of specialties, but we're just getting that launched.
Got it. Thank you. I appreciate that. I want to go ahead and start taking some questions from the audience while we have you both here. So I'm going to pivot to that. We've got a few already. And before I get that, Kathleen says, former Yale instructor here, go Bulldogs. Actually, there's a lot of love for Yale in the comments so far. So yeah. Where's the one that I had? Okay. From Anita, could you please tell me what is the difference between octreotide, LAR, and lanreotide autogel? As I've been on octreotide for many years and they think it isn't working anymore, so now they've put me on lanreotide. This is actually kind of a common question.
Yeah, I'm happy to tackle that, and we can maybe then sort of weave in the importance of somatostatin receptors, and Dr. Aboian can talk about that.
Perfect.
So octreotide there are two formulations. There's a long-acting formulation and a short-acting formulation. It's been around a long time, since the 1980s. Lanreotide is a newer formulation. They are both considered in the class of somatostatin analogs, and so they're made by different companies, but they really have the same exact mechanism of action. They have a strong affinity for somatostatin receptor type 2. There are 5 different somatostatin receptor types. Octreotide is formally FDA approved for hormone control, whereas lanreotide is formally FDA approved for both hormone control and tumor control. So we know that originally somatostatin analogs, the octreotide was developed to reduce symptoms from carcinoid syndrome, diarrhea, flushing. Somatostatin analogs are the mainstay for how we treat patients who have functional nets, who secrete hormones. But what we learned is that somatostatin analogs also slow the growth of nets and are actually an anti-tumor treatment, and often one of our first-line treatments. So to answer the audience member's question, I would say it depends a little bit. So if a patient is being switched from one to the other for hormone control, or sometimes patients will have side effects on one lanreotide versus octreotide, we might make that switch. In general, we don't make a switch from one to the other for tumor control, just because they work almost identically. And the only other main difference is that octreotide is an intramuscular injection and lanreotide is a deep subcutaneous injection. So but one of our real collaborations, and Dr. Aboian and I talk about this, is how can we really take advantage of that somatostatin receptor? So I don't know, Rena, if you want to mention that, or if you want to just go to the other audience questions.
No, I'm happy to expand on that, please.
So a lot of times, just to follow up, I'm so glad, Pam, you're here, because when it comes to medical oncology, I don't always know all the details. But in terms of somatostatin receptor imaging, we do have we perform PET imaging for visualizing the receptors, and basically we can quantitate them on the receptors. But in clinical practice, we actually do visual assessment and can estimate whether it's high expressing tumor of somatostatin receptor or low expressing or medium expressing. But we can actually use advanced PET techniques to truly quantitate the number of receptors on tumors, although we still don't really know whether that's going to be useful for therapy. Right now, just quantifying it in terms of general categories of high expressors versus low expressors is enough, but we'll see. Maybe in the future, as we develop dosimetry more and start figuring out how individual tumors in the same patient behave differently with the informatics tools that we're developing, maybe that's where we will need more quantitative analysis of amount of receptors within individual tumors.
Got it. Thank you. Folks, if you just joined us or joined us a little bit late, this is Luncheon with the Experts at Carcinoid Cancer Foundation program. And today we have a special episode. We have Doctors Mariam Aboian and Dr. Pamela Kunz, both joining us live from Nanets. So we're giving you a little peek behind the scenes there, but also we're going to take as many of your questions as possible. So keep sending them in. And if you know anybody that should be here for this special edition show, go ahead and tag them in the comments, share the video with them, let them know what's going on. We've got a little while, plenty of time left actually. So send in your questions. We'll get to as many as possible. Next question comes from Karen. Karen says, what is the best scan to measure tumor size?
That is a great question because you can do multiple different scans to measure tumor size, and it depends on the tumor location also. So you can do a CT, which will actually provide really good information as long as you can differentiate the boundaries of the tumor. Sometimes the tumor can be in a location where the boundaries are hard to see. You can do CT with contrast, which will help you see the boundaries a little bit better. And you can do contrast at different phases of injection. So you can see early injection or late injection. Ooh, they're announcing.
That's okay.
They're announcing live. By the way, I wanted to let you know that Dr. Kunz is the president of NANETS this year.
Starting in after this meeting. So I'm soon to be president. Yeah.
So next year's will be out of this world.
Yeah, it's going to be amazing. Yeah.
I'll have to go to next year's. Yes, absolutely. No, that is awesome.
So then you can also use MRI to do the measurements, and which is really fantastic for measurements, as long as you get a thin slice MRI, not thick slice MRI, because sometimes you can actually overestimate or underestimate tumor size depending on the slices in between the on the slice thickness of the MRI. You can also use PET. Although it's actually measuring the tracer avid tumor is not as accurate in terms of the size. But then there's this big dilemma that I'm actually trying to answer in my group is, should we be using two-dimensional measurements or volumetric measurements of tumors, right? And the reason why we don't use volumetric measurements is because we just don't have the tools in the clinic to do it as easily. But in reality, if you look at two-dimensional measurements and you take one radiologist and you have them do them on one day and a month later, they may be actually fairly different.
Yeah.
And the difference between individual radiologists at different time points or multiple radiologists at the same time point can also be significantly different. So what do you follow for treatment response? So we're trying to answer that. We're hoping it's going to be volumetry, and we're developing the tools for the volumetrics right now.
That's exciting. No, that you explained that very well. That makes a lot of sense to me, who is by no means a medical expert.
Can I add as the non-radiologist, because I have to come up with analogies to explain this. Yeah,
you do that very well. I remember.
And so, because this is it's a great question. It's one that I get asked a lot in clinic, and I completely agree with what Dr. Aboian said. So we really use CTs or MRIs as the primary tool to monitor size over time. The DOTA PET scans really complement that, though. But the way I describe the DOTA PET is that it shows us extent of disease, where the tumor is in the body, with the use of this light bulb. So if you have a light bulb, the DOTA PET shows us the glow of the light bulb, but not the size of the light bulb.
Okay.
So that's sort of the way, and they really complement each other. But like Dr. Aboian said, the glow is important, but it doesn't help us measure the size very well.
It's a really good point. Next question. Oh, by the way, Dr. Aboian, it probably is more distracting to you than it is to us when you hear that. I mean, I still continue to keep it muted when you're not answering, but it picks up your voice and isolates your voice really well on our end. So don't mind that too much. But we're gonna rock with it today. I love it. From Robin, this is a good question. How hard is it for net researchers and specialists to get non-net oncologists to learn more about NETs when they are so busy in their practice?
That's an awesome question. And it is. Yep. And I think that's in fact a really important mission of NANETS, is that we do something called regional meetings. Is something that we sponsor that are intended to be educational meetings for community medical oncologists, community providers that don't necessarily specialize in NETs. Our outreach is also expanding to do podcasts and other webinars to really get the message out. And I think that there's an education gap that we as NET professionals need to try to meet. So we know that patients often feel like they have this burden of, and come join. I'm doing here, you can see my friends.
Hey, everyone.
Rain Bennett, and I know. I'm gonna eat. Anyway, the benefits of being in, I'm in the networking lounge. Okay, here, I'll shift, here, I'll go like this. Okay, there we go.
Perfect.
So, but I'd say that one of the benefits and a real mission of NANETS and something that we've recognized is trying to get that message out to the community.
Absolutely. Okay, next question from Caitlin. What testing should be done if a PET gallium scan shows uptake in the sternum? Is there a treatment for sternum nets?
And Rain, I'm going to take that as my cue to step off. I'm going to let Dr. Aboian answer that. And thank you so much for allowing me to join you guys.
Oh, absolutely. Anytime. I appreciate it very much.
All right. Thank you. Take care.
Bye-bye.
Thank you so much for joining. It's such a pleasure for Dr. Kunz to join, and she's so busy because she's so involved.
The new president of NANETS.
Yeah, so
we're grateful.
So lucky to have her join. So let's go back to the sternum.
Yes. So do you want me to ask that question again?
Oh, I think I got it.
Cool.
So if there's dotatate uptake within the sternum and there's and it's fairly high uptake, then it's most likely a metastasis within the sternum. So then it would be really important to follow the oncologist's recommendation for how they're treating the whole body disease in terms of, are they going to target a therapy for particularly that lesion? Maybe it's causing pain, maybe it's causing problems, maybe it fractured. Sometimes you can have fractures of osseous fractures related to the tumor. So it depends on the whole clinical situation. Does the entire disease getting treated, the other lesions, are they getting treated in another method? So it's really hard to specifically ask, to specifically determine exactly what individual lesion is going to be treated like. You always want to think about it in terms of the entire disease. But the first thing is to make sure that the dotatate uptake is really related to the tumor. So you can either, it depends on how it looks like on imaging. If it does look like a metastasis, then you can proceed to the next step. If it's unclear and it's only mild uptake, maybe an MRI is useful to try to figure out if it's a metastasis or not. But if your oncologist believes that it's a true metastasis, then we need to look at the whole picture of how the rest of the disease is being treated and whether this particular lesion requires precision therapy. I hope that answers it.
Yeah, I mean, I think so. And if it didn't, Kaylin, just let us know. And this goes for anybody. If you have follow-up questions or questions that have spawned off of the answer, or if, we didn't understand and you need to clarify all of that. If you're still in the call, always feel free to chime back in, please. This is an interesting one. I'm not sure. I'm going to ask it and see if you feel like you can field it, but I don't think I've seen this one before. So I like to ask new questions. Sandra says, well, first of all, thank you for all that you are doing. And I'm very interested in how a registry is formed, as we need one, national and international. I belong to an international Facebook group, Living with Rare Lung Disease DIPNEC. She's a recently diagnosed DIPNEC patient of Dr. Ramirez at Vanderbilt, who's a friend of the foundation. But yeah, any thoughts about that? Like, is there a registry, how we would go about it, or any of that? Have you ever thought about that?
That is a great question, because we do need registries, and we do need registries. I'm a database builder, so registries I do it on a much smaller scale. But the idea is, it is very important, particularly for rare diseases, to build registries and to build databases of outcomes, of any kind of predictors. And when you're a member of a Facebook group where there's a lot of patients, it's an incredibly powerful platform, because you can identify predictors that we in the clinic may not be able to identify. Because sometimes when a patient comes in and starts talking to the physician, they don't mention every single symptom that they may have. But when you're on Facebook and you're in the comment section, you can actually mention a lot of the issues that you're having. And sometimes it's a lot easier to mention in a comment section, where in a group of friends who understand you, right? So I think is a very being able to harness the information from patient Facebook groups. And I think it has to come from patients because it's really important to be very sensitive to different experiences and really present the information that will protect the folks that are sharing the information as well. But pulling out the pearls from those information and things like brain fog, and really highlighting issues with brain fog that a lot of times in medical community we don't realize how serious the problem with brain fog happens after chemotherapy.
Yeah.
And being able to publish that information is really, really important. I also see this actually in the brain tumors sphere, where there's actually Facebook groups of long-term survivors of glioblastoma. Now, we know glioblastoma is a very aggressive disorder with very short survival, but there's actually a lot of patients that report very long survival, and a lot of patients report misdiagnoses of glioblastoma that we don't really get a chance to study in the clinic very much because we usually don't have these patients come to us and tell us this. So being able to curate this information, and if you have an ability to accumulate the information and list the important points from those conversations to start building those kinds of databases, that would be fantastic. Now, the other thing that's really important about building databases is making sure that they're centralized and available for everybody, for all the researchers, because there's a big issue that's going on in research right now, and that is lack of reproducibility of research. And somebody will do something in their lab in a very specific environment with very specific tools and expertise, and another person in another lab will have trouble reproducing it because they may not have the same expertise, they may not have the same reagents, they may not have the same, magic dust that was like floating that made that experiment work. So the way to combat this is to really make data sets open. And this is something that I recently learned at the MICI Society meeting, where it's a medical imaging informatics meeting where they really focus on machine learning and medical image interpretation. And what is done at MICI is we usually will combine data sets of images and patient outcomes, and they have to be very carefully curated because you don't want any of that information to be identifiable. So you create these data sets, and then you provide the clinical question to a group of engineers and data scientists that may not know a lot about medicine, and they will find algorithms to answer the question because of their computer science expertise. And then you actually have a list of different algorithms that you can start applying to the question and start translating back into the clinic. So it's a really great way to form an environment where you can identify the best algorithms for prediction survival, prediction of metastatic patterns, prediction of how tumor is going to respond to a specific drug, right? As long as you can formulate a question and present it in that platform, you can actually open this up to open science and develop algorithms in that platform. And once you can figure out these algorithms, you can take them back to your clinic and start applying them to patients and actually start running clinical trials in terms of safety of applying these algorithms. So having these kinds of registries really opens up to innovative approaches to how we monitor disease, to how we monitor treatment response, and how we predict treatment response. So your idea is brilliant. And if you need any help with forming this, please reach out to me. My email is on the Yale website, Mariam Aboian@yale.edu, and I would love to be involved in these kinds of efforts because I really believe it's important to make your voice heard.
Love it. Great answer. And that's echoed by the comments in the comment section as well. Thanks, Sandra, for your question. That was great. Well, this one, you may have answered this question in a previous answer. I'll still ask it because it's quick. Kathleen says, does Yale use PET MRI or PET CT?
Yes, so we use PET CT. We're about to get a PET MRI. I'm a firm proponent of PET MRI because I believe, first of all, it is really important to do anatomic and functional imaging at the same time because you can really study these processes together. And second of all, I'm a firm believer that your time is precious. I really don't want to spend the entire day in the hospital getting the MRI, then waiting in line and waiting in the holding area for the PET. I want
Yeah,
all of this done in 1 hour, and then have you go back to your life. So
it's a
I
great
think
point.
the benefit of workflow efficiency of PET MRI is underestimated in the medical community. But the patients realize this because when you have to do these multiple studies, you spend your entire day going in because you first have to park, you have to drive, you have to park, you have to do the imaging for one modality, then the other modality, and you're of course fasting for all of them, so you're not eating the entire
Right.
day, right? So I think PET MRI is really the way we should be doing this. I'm advocating to our Yale leadership that a large part of the PET MRI is going to be done for oncology uses. Right now, the discussion is to put this into the neurosciences towers. So hopefully we will be using PET MRI for oncology uses soon.
Got it. Thanks, Kathleen. Great question. Next question, and I've certainly had this one before, or a similar version of it. Diane says, should there be a limit on the number of radiology tests done in a year, i.e. CT, MRI, PET scan twice? And just for some context, Diane is still trying to locate the primary.
Oh, you're still trying to find the primary. Wow.
So
You're
probably a
going,
lot of scans, and curious about, should there be a limit on that?
yeah, that is quite a journey. A lot of the times, the major guiding principle in medicine is do no harm, right?
Right.
So, and in imaging, we also do a very similar principle, image lightly. So we really try to minimize the dose of radiation that we provide with imaging. So one of the things we try to avoid is to limit the amount of CTs and limit the amount of PET CTs. And MRI also has, it's not a radiation dose, but MRI also has its own risks related to it as well. So it's fairly safe, but we also don't like to over image with MR scans as well. On top of it, when we image more, we also find a lot of incidental findings. And you would think, oh, it's an incidental finding, it's not something important. But the moment you start working it up, and if you start working it up invasively, that's where complications can start happening. So you have to balance the amount of imaging you receive to the amount of imaging you need. So there really isn't a defined limit in terms of how many studies you can get. It's more of a discussion with your ordering provider, with your physician who is going over your disease and trying to figure out what else you need to, what else needs to be addressed to figure out what's going on. So if you're trying to find a primary, and I don't know what kind of test you had, but you may need the additional tests to figure out where the primary is. So that would be my answer to that.
Got it. Thank you. So I know just from the job that I have here and talking to a lot of people in the field that there's quite a lot of activity going on right now in the net space, in the net world, right? And especially in terms of research. Talk to me a little bit about that, like either what you're involved in or some of the things that you are excited about, because it really seems to be a flurry of activity. I know what we've accomplished in the past 10 years, but I'm really hopeful for the next 5 to 10 because of so much activity going on. What's exciting out there? What are you hopeful for? What talk to me about all of that.
Well, I'm extremely lucky to be early in my career as the field of neuroendocrine tumor research is really flourishing.
Yeah.
There's, and I'm very lucky to be mentored by Dr. Kunz. So I really just want to make sure I acknowledge how important it is in my path and how without her, I wouldn't be doing what I'm doing.
I understand.
So, and there's a, and she actually mentors a lot of junior faculty. So she's quite a treasure to us. So one of the very exciting areas that I am interested in pursuing is asking very basic questions. How do we measure tumors? Can we bring reliable measurements into clinical practice? Can we translate these measurements into personalized dosimetry for patients, for every single patient? Can we define the dose that each individual tumor needs to get to respond to treatment? Those questions I'm really excited about, because I like to think about disease in terms of whole body disease, but also individual tumor disease. Sure. And can we personalize treatment to whole body and individual tumors at the same time? And can we do quantitative measures that we haven't been able to do before? Now, the other part is, with Lutathera being available, I'm really excied about the actinium therapies, the alpha therapy, alpha particle therapies that are coming aboard, and how do we choose? When do we do Lutathera? When do we use alpha therapy? And how do we combine it with immunotherapy approaches and any other chemotherapeutic approaches? How do we combine these different treatments? What is the sequence of events that we should be doing? And this is where these kinds of quantitative tools are going to be critical, because we will never figure out combination therapies and how tumor responds to it if we don't know how to measure treatment response. So if we're using current methods for treatment response, it's not the best way to measure treatment response. So if we can start using volumetrics for treatment response, if we start using differentiating solid tumor from necrosis and how necrosis is developing over time, those are metrics that are really important for following treatment response. So I actually think with all of these new developments, we kind of have to take a step back and reevaluate the tools that we use and really focus on the basics, such as dosimetry, measurements, outcome measurements, and really ask those questions again, because I have a feeling a lot of the answers are there.
It's a great response. I have a follow-up question. You may have addressed it in your previous answer, but other than those simple questions that you like to ask, which I love that as your starting point and your guiding principles, looking at in terms of research, are there other areas that we aren't currently pursuing or looking into that are still gaps and challenges that you think in the next stage should be addressed? Does that make sense? Like, there are a lot of studies going on now focusing on certain aspects of this, right? Combination treatments, et cetera. What are the areas that aren't as explored as you would like to see right now?
Dosimetry.
Yeah. Okay.
Dosimetry. I just feel like there's a lot of interest in dosimetry, and we're not able to do it because it's not getting reimbursed.
Yeah.
And every time we try to include dosimetry, there's a major resistance to include it because it's not being reimbursed. And we have to get grants to be able to fund dosimetry studies, and getting grants can take up to 2 years. So I just got my first NIH grant on imaging of PD-L1 in head and neck cancer and brain metastases. It took me 2 years to get that grant. And actually, I started it took me 3 years to get that grant. I started writing it when I just started at Yale, and I'm now 3 years and my study is finally open. So to be able to get those grants is really difficult, and it requires a lot of persistence, and we do get them eventually. But the big issue is that it's a lot easier to do studies on dotatate PET because that gets reimbursed. It's a lot easier to do studies on theranostics because they're getting reimbursed. But figuring out a way to sponsor dosimetry, or maybe even if patient advocacy advocates to Medicare and basically says, this is important. Being able to do dosimetry is critical, and that needs to be reimbursed so doctors can actually do it. A lot of us will start doing a lot more studies on it because we will finally be able to do it. We will finally be able to incorporate it into clinical practice. It is standard of care in radiation oncology to do dosimetry. So all of the interventions that are done with dosimetry evaluation. So in nuclear medicine, we need that as well. And I feel like that is an area that will explode the moment we get a chance to, the moment we're allowed to.
Yeah. It's a good point. You don't see this on your end since you're just on Zoom with me, but there was a flurry of heart emojis that came across my screen on that last answer. So it's really resonating with people what you're saying. I just wanted to let you know about that because I see that visual. Yeah, I see that visual cue, but you don't. You just see my face. Oh, there's more coming in now. Look what happens when you prompt them. What do you have?
Personalized treatments. We need them. Right therapy, right dose.
Yeah, the people are responding 100%. What do you have going on? What are the sessions that you're attending once we get off, like this afternoon? What are you excited about?
I'm very excited about that and NIH and CI research retreat. That's going to be really definitely a highlight for me. So that's and then Dr. Kunz is giving a keynote lecture tomorrow, so I'm very excited about that.
Awesome. Is that the opening keynote, like in the morning?
Yes. So definitely try to log in if you're able to. But yeah, I'm actually just kind of taking it in at this point. I'm very like I'm meeting everybody. There's a lot of discussions in the hallways where we're discussing different projects, and
that's where the good stuff happens sometimes, you know.
Exactly.
Those that are like transient chats that you have. Is there anybody that you're excited to meet?
Oh
Or
gosh.
specifically like
Well, so I'm a huge fan of Dr. Nicholas Fidelman from UCSF. He was my teacher at when I was a resident, and he talked today about liver-directed therapies, and he has been such a leader in the field. So I'm actually really excited to talk to him. I had to run out of his session to join you guys.
Oh, well, thank you for that sacrifice.
But you should invite him to a future session. He's brilliant.
That's it's a great point. I'll follow up with you on that when we start back up. Sandra says, I'm sorry, this one's directed towards me. You are great to offer this program and ask great questions. Well, thank you, Sandra, so much. I appreciate that, and all praise to CCF for the program. I am just the host. But Sandra does have this question for you, Dr. Aboian. Is an HRCT image, which is high resolution, better imaging for tumors than a CT with contrast?
Oh, so HRCT for lung, right?
I don't.
Yeah, high resolution CT. You know, when I was a resident, I remember we used to
yes, correct. You're correct there.
Yeah, so HRCT is actually being used for like interstitial lung disorder. So it's actually a very different approach. It sounds like it's better because it says high resolution CT.
Right, exactly.
Right. But it's actually not. I would do the post-contrast CT of the chest to see better, because you actually see thin slice imaging and you can actually see the tumor borders much better. HRCT is much better for parenchymal evaluation and like the interstitial lung disease changes. And it's done actually as a dynamic study. So there's like a breathing in an expiration phase. So it's an unfortunate name.
Got it.
Because it confuses a lot of people.
Yeah, no. So that was a great question, Sandra. I appreciate that. And thanks for the clarification. That's very helpful. About the Nanets Symposium, Felice says, is that open to the public or is that just for the medical professionals only?
You know, it's a great question. So I believe anyone can come. There's a registration that you can just register on the Nanets website and attend any of the lectures. And I don't think you need to have, it's for everybody. I don't think you need a medical degree to be here, because we have people of all walks of life here. There is a registration fee that supports the meeting, but I do encourage to, I'm pretty sure there's a virtual option as well. I decided to come in person today because I really do need to meet the community to build the future research. And I feel like I get a lot more from live events in terms of learning and networking opportunities. But I do recommend to come next year for sure, and register and come and talk to us, and stop me in the hallway, and we'll chat and talk about research and all the cool sessions. I think it's a great way to learn about the disease and the research that's going on and any kind of the initiatives that are being done in the field.
Got it. Thank you. And folks, we just put that the link in the comment section so you can check that out too. Dr. Aboian, I know that you are a patient advocate. I know that you're fighting for the people. I think it's very special to me, and I see that echoed in a lot of net experts. So I'm curious, if you kind of switch to that focus right now and think about the patient, as we've had in this episode alone, and every week we have people that are new to this show, new to this journey, new to this disease. What is your advice, your first round of advice to a newly diagnosed patient to navigate this disease, to where do they start? They're scared, they're confused, it's a new word, the rare cancer. What do you say to that person?
Yeah. Anytime you face a fork in life, right? Or you face this challenge, and you face your mortality, right? You face who you are. It's extremely scary, and it is at the same time it's extremely disorienting, and you don't know who to talk to. And so the most important thing is to really talk to your oncologist, and to really spend time with them and really develop that relationship with them. And sometimes you won't build it in one visit, you'll build it over time. And really have a genuine conversation with the oncologist, and really have time to spend with them. I'm trying to bring clinic visits. Well, Dr. Kunz and I, we're trying to bring clinic visits to nuclear medicine as well, because I shouldn't just be injecting Lutathera into my patients with a short conversation right before I inject them. I really need the time to spend to talk to you and to talk about your process, where you are in the journey of the therapy, where you are in your psychological state in terms of how you're handling the disease. So we're going to be implementing that at Yale as well, where we'll have clinical visits with me as well as with Dr. Kunz. And another thing that's really, really important is to build your tribe, and build your group of supporters. And within the Carcinoid Cancer Foundation, there's tremendous support from the community. And just don't be afraid to reach out and say, hey, I don't know what's going on. I don't know. I'm scared. Can somebody talk to me? And there's going to be somebody who's been through it, who may have just gone through it or has gone through it several years ago, and they will provide advice, and you'll build your tribe this way. So then when you do have questions, or when you do have, when you are scared, you have people to reach out to. And sometimes it's hard to get an appointment with an oncologist, and it's hard to get an appointment with nuclear medicine physician or your primary doctor. I have trouble making appointments with my doctor as well. So having that tribe that, when you're at midnight and you're scared and you don't know what to do, you can type a few questions into a forum, and there will be a lot of people who will be able to answer that question for you and be there for you. Also, having frank conversations with family is really, really important, because a lot of times that's a really strong source of support. And also, there was one lecture today that really struck me, and that was, how do we measure our life? how do we measure where we're going? And it wasn't an early career session, but one of the points of it was, what is the impact that we're doing? And this is where you center yourself on what is the point of your life? What is the impact that you are going to be leaving on this life? Because this life is not forever for all of us. So everyone is going to be done with this life one point or another. So really centering on what that impact is, what are you leaving behind, is really, really important. And how you're influencing your environment on your daily basis. Even through your fears, because if you're afraid of the situation, if you're scared and it is such a difficult thing, there's somebody else who's the same way. And maybe it will make their day better knowing that somebody else is struggling with the same issue. And then you can talk to each other, and it may make both of your journeys easier.
It does.
So
and then you learn from each other as well. I mean, having that empathy is huge for making us feel seen and understood. But then also when if that person is able to solve that problem, they can, share that with you. And that's helpful too on a, in an objective manner. Not, before we go, I had a follow-up question that a few people have to that previous answer. It's like, Sarah says, what if you don't have an oncologist? I just have the GI doctor that took out the tumor, and a couple of people have chimed in like, yeah, me too. I'm confused about the whole thing. So thoughts about someone who doesn't have an oncologist, do they need to seek that out, where, etc.?
Yeah. So the way neuroendocrine tumors are treated is a multidisciplinary approach. It has to be a team. So finding an oncologist is really important. Somebody you can go to who can be like the quarterback for the whole team, and who can basically tell you, for local therapy for sternal tumor, we'll go here, and for local therapy for liver tumor, we'll go here, and to treat the entire disease, we'll do this. So finding an oncologist is really, really important, because you need somebody centralized who you can go to and say, hey, I'm scared. What do I do? We just resected this tumor. Is there any other disease? Do we need to be searching for any other disease? Do we need any additional imaging? Do we need any additional interventions, or is it okay to wait for another couple of years? So having that central person, so definitely it's important to find an oncologist.
Folks, one of the things that COVID did bring us was, easier telehealth and video conferencing. So a lot of our guests on the show are like, message me, we'll schedule something. It's much easier for them to do it. And even if they don't become your oncologist, they can potentially, it's a big network. Everyone knows everyone because it's a small community, but a strong network, I should say, rather than big. So often you can get a good referral from that specialist. Everybody on the show says that. And then I just want to comment, Ruby says that, hospital schedule visits for 20 minutes. These shows have been a lifesaver. I'm extremely grateful and looking forward to next year. Thank you, first of all, Ruby, but also this is our goal. This is our mission here with the show. So I appreciate you saying that. This is our job. And so lean on us as well. Message a foundation, definitely watch the shows, and we'll try to get you the right people that can help you and be part of that team that Dr. Aboian was mentioning. That is our hour, folks. Dr. Aboian, thank you so much for making time out of your day from Nanets, which is very exciting. Give us one more peek to what's going on around you, just so that people can see. Look, boom, a lot of activity going on. That's exciting. I wish I was there. Folks, everyone, thank you so much. This has been a great year. We started this in July of 2020, which is, it's a long time ago. We've done a lot of episodes, and we will continue the show, but not for 2022. We are going to take a break for the holidays, for the end of the year. Thank you all for everything. And just stay tuned. We'll let you know. In the meantime, one last little plug. We have a documentary series that is going on right now. We just released episode 3 with a very inspirational story from Corey Berliner, now Huminski. And it's pinned on our Facebook page. Great story. Awesome woman, and a net thriver. So check that out when you have time. Everyone, Dr. Aboian, appreciate you being here as always. I'm glad you could fit us in. And to you folks at home, as always, I hope this program helped answer some of your questions. Please reach out to CCF if you have any more. Thanks as always to our presenting sponsor, Ipsen Biopharmaceuticals. And finally, folks, my name is Rain Bennett. I have been your host. Thank you for watching. And please join us next time, which will effectively be next year, for Luncheon with the Experts. Stay healthy, stay safe, everyone. Bye-bye.